Atrial fibrillation and atrial flutter are two similar cousin rhythm disorders. The approach to them can be similar in many ways, and many patients have both of them. Thus, we will talk about them together. First, before we treat the AFib or aflutter, we typically perform tests to see if there are other causes or contributing factors. This may include blood work, an echocardiogram, sleep study looking for sleep apnea, etc. In atrial fibrillation and atrial flutter, the top chambers of the heart, the atria, are beating very fast and basically quivering. This results in several issues, and we typically think of the treatment strategy as having three parallel approaches. First, when the atrium is quivering, the blood doesn't move well. When blood lays still, it can form a clot, which can then leave the heart and go to the brain, and thus cause a stroke. That is the most dangerous thing about this rhythm. Thus, we look at each patient and we ask ourselves what that patient's risk of stroke is and what we can do about it. To decrease the risk of stroke, we typically use aspirin, true blood thinners, or sometimes even a procedure to block off the area of the heart where most stroke-causing clots come from. Not everyone needs true blood thinners. We use blood thinners when the risk of stroke is higher than the risk of bleeding from the blood thinners. We measure a patient's stroke risk by asking several questions and giving the patient a point for each of the following: congestive heart failure, high blood pressure, age over 65, diabetes, vascular disease, and female gender. They get 2 points for age over 75 or for a prior stroke. If a patient's score is 1, we consider aspirin or true blood thinners. If a patient's score is 2 or greater, we typically recommend true blood thinners. The second part of our approach to treating AFib and aflutter is controlling the rate of the bottom main pumping chambers of the heart, the ventricles. When the top chambers, the atria, are quivering so fast, they tend to drive the ventricles to pump very fast as well. Thus, we often use medications that don't necessarily keep you in rhythm, but do help slow your heart rate down. So in other words, they won't make it less likely for you to have AFib or aflutter, but at least when you are out of rhythm, your heart rate will not be as fast. By controlling your heart rate, we can often lessen symptoms or make them completely go away. Sometimes, the heart rates can become difficult to control with medicine alone, and in fact, may get too slow. In these situations, we may recommend placing a pacemaker to keep the heart rates from getting too slow, and thus allowing us to use medicine to keep the heart rates from getting too fast. This keeps the rates in a normal range. The third part of our approach to AFib or aflutter is what we call rhythm control. This is where we use one or more of the following: cardioversion, shocking the heart into rhythm, special antiarrhythmic drugs, and or ablation, a procedure where we cauterize inside the heart to get rid of the rhythm. The benefit of the rhythm control strategy is to make you feel better. Thus, we usually only pursue this strategy when a patient has symptoms from their AFib or aflutter. If a patient does in fact have symptoms, then we discuss the options of antiarrhythmic drugs and or ablation.